Welcome to A Real Affliction, BPD, Culture, and Stigma, an interview podcast that explores how we live with, treat, advocate for, write about, and conceptualize borderline personality disorder. My name is Cynthia Gralla. Actually, today will not be an interview. I am recording this episode solo and mostly without a script, just to talk about doctor and patient intercommunication for people with BPD. It can be really difficult for any patient to communicate with a clinician, whether they are a medical doctor, a nurse, a social worker, a therapist, and especially when BPD is involved. The reason is that there is a lot of stigma in the medical community. As I talk about in some of my other interviews and episodes, it does seem like a lot of the stigma surrounding BPD actually originates in medical schools and other professional training situations. So it's difficult for many clinicians to really empathize and understand a patient who is displaying traits of BPD or suspects that they have it. And that's only one half of the difficulty. I think many of us, most people I know actually, experience some difficulties explaining themselves and listening. When you're the patient, you're not just articulating your experience and your suffering to a clinician, you're also listening to what they say. Now, I want to be very clear. I'm not victim blaming. If you're trying to explain yourself to a medical care provider who is saying stigmatizing things and just not really listening to what you're saying, that's not your fault. But the reality of interpersonal communication is that to have successful communication, we have to try on both sides. So I want to give tips first to those on the clinician side, because I know I have some therapists who listen to this podcast, but also tips for patients, especially during those early appointments where you're trying to tell your story and explain what's going on with you, what isn't working well in your life because of emotional dysregulation or whatever aspect of BPD or other mental health disorders, and how doctors and other treatment providers can become better at listening to their patients' stories and decoding them, really, to figure out what the diagnosis might be and what is the best approach to helping this singular patient, because everyone is different. The good news on the clinician side, there is a growing field called narrative medicine. Narrative medicine is also called narrative-based medicine in the UK especially, and often in Canada. But in the US, it tends to be narrative medicine. And in the US, it was spearheaded by a woman named Dr. Rita Sharon. Dr. Sharon is a medical doctor who went back and got her PhD in English. So she has expertise both in medical issues, but also stories. And with other people, both on the literature and medical side, she developed a program at Columbia University in narrative medicine. And the entire point of the program is to teach any clinician, a nurse, therapist, psychiatrist, internist, what have you, to teach them to elicit, listen to, and understand patients' stories better. That's really the thrust of the whole field or discipline of narrative medicine. It is an interdisciplinary field drawing on fields including, of course, medicine, psychology, literature, philosophy, sociology. But the main way they teach clinicians to do this is by asking them to study stories, to look at narrative structure in literature, and to write their own stories. So narrative medicine classes tend to ask people to do close readings of literature, but also do some creative writing and to reflect on their clinical practice and their experience with patients. Its key principles are intersubjectivity, trying to kind of reach across your experience of the world and your feelings about the world to understand someone else's experience and feelings. Relationality, understanding that we're all connected in this ecosystem that requires us to see ourselves as part of a whole. It also stresses personhood and embodiment. I think in our daily lives, so much of which are spent online, on social media, on Zoom, we can forget that we are embodied people who feel all kinds of joys and pain in that body. It's also motivated by social justice, close reading, and its corollary, slow looking. How can you really see someone who's in front of you? And it doesn't necessarily involve staring at someone until they're completely uncomfortable, but really just attending to small details of that embodied person. Are they slouching? Are they sitting up straight? Do they have certain gestures that might indicate anxiety or discomfort? Things like that. And finally, it stresses creativity. And like I said, its chief methods are teaching clinicians close reading and creative writing, especially reflective writing about their experience in providing treatment to vulnerable people. I was lucky enough to take a course in narrative-based medicine through the University of Toronto earlier this year. And I'm happy to say that my fellow students were wonderful. Not all of them were clinicians. Some were writers and educators like me who are interested in bringing narrative medicine into more of our writing or literature courses. But many of them were medical doctors, psychiatrists, oncologists. There were a few nurses as well, at least a couple of social workers. So for me, it was really heartening to see them in their attempts to understand patients' stories better. And I'll say it was even healing because I, like many people with a history of BPD, had horrible experiences with clinicians when I was younger. There's no way to sugarcoat it. From my very first hospitalization in 1985 at age 11, I had really terrible experiences because people weren't as enlightened back then about mental health conditions, and they tended to blame the victim all the time, including an 11-year-old terrified child. So for me, seeing my peers in that class, those who provide healthcare, try to grow and develop their empathy and their ability to understand what patients are telling them, that was really nurturing and healing for me. So I think narrative medicine is a huge piece of the puzzle in decreasing stigma against BPD and other stigmatized mental and physical health conditions. Certainly, there are other ways to do it. One way would be by revising medical school curriculum or social work school curriculum so that when people introduce certain disorders, it's not with stigmatizing language and it includes words from people who have experienced the condition that they're studying and maybe even visits to the class of those people. I would recommend that everyone who provides a treatment of some kind take a class in narrative medicine and just think about stories. Because even for a medical doctor, this isn't just therapists or psychiatrists, even medical doctors have to take what they call a patient history. And one of the things that Dr. Sharon points out is that the structure of the questions, there tends to be a pretty set format to take that patient history, but that structure may not work for every patient. So there are different ways to elicit those stories that might involve veering from that script based on that singular, amazing individual in front of you. I would also suggest that other people might benefit from taking a course in narrative medicine, or if they can't find that near them, at least medical humanities. Those courses often cover similar things. They'll usually expose you to literature about health issues, often written by patients or even doctors. A lot of doctors write creatively. I think people in fields like anthropology, sociology, any field where you might be doing qualitative research and interviewing people, you could benefit from such a course. Also, people who study gender studies, disability studies, bioethics, interdisciplinary scholars, I think all of these people could benefit. But even if every clinician, everyone doing interviews did improve their ability to elicit, listen to, and understand the stories of patients or interviewees, that would still be only half of the solution. I think the other half lies in the difficulty that many of us have or have had in expressing distress in a conversation with a treatment care provider. And this distress could be physical or mental or both, but it's really hard, especially on a first meeting. The first meeting of a therapist, a general practitioner, a psychiatrist is so critical. It establishes the relationship and the trust between the two parties, or it should. It should give both of you a grounding in what is going on with you so the clinician can start developing a treatment plan. But it's really stressful and confusing to try to explain what you're experiencing to a stranger. You're often trying to explain the most personal details about yourself to someone you don't know. So that is part of the problem. There's no easy fix to that. I don't think that initial giving of a patient history, or if we want to phrase it as that first time you as a patient tell your story to someone who you hope will help you, there's no way that's going to be easy. And I just want to offer a few tips from my own experience and thinking about narrative medicine. I would say that learning to tell your story is also part of self-advocacy in medical treatment. It's speaking up and explaining what you need. And I want to say, first of all, that I think self-advocacy in medical settings is one of the most important things we can learn how to do, especially for anyone who isn't a cisgender man, and especially isn't a cisgender white straight man. Now, I'm not saying that cisgender straight white men don't have problems. In fact, there seems to be a health crisis among men, young men and middle-aged men. I'm not minimizing that. For anyone who identifies as a woman, I would strongly recommend a book called Doing Harm: The Truth About How Bad Medicine and Lazy Science Leave Women Dismissed, Misdiagnosed, and Sick. It's written by Maya Dusenberry. It came out a few years ago, and it was really impactful on me. She talks about how, basically like the title says, how women are often misdiagnosed or their medical concerns are dismissed when they go to an emergency room or a visit with their general practitioner. And I'll give one example that she offers. In one section of the book, she talks about women and autoimmune diseases. And this was really interesting to me because I have systemic lupus. And she explained that despite the fact that 90% of patients with systemic lupus are women, people don't fully know why, but it does seem to be connected to hormones in some way. Despite the fact that only 10% of the patients are men, men get diagnosed with systemic lupus 4 or 5 times faster than women do on average. It takes a man who ends up with a systemic lupus diagnosis on average about 1 year to diagnose. It's a tricky disease, and you might not have enough to meet the criteria for it until you're very ill. That's what happened with me. So men take about a year to get diagnosed with it. Women on average take 4 or 5 years to get a correct diagnosis of systemic lupus. Why? Why do men get it so much faster when it shouldn't logically be the first thing a doctor thinks of? And if it takes on average a year, it's not the first thing, but still they come to that idea that men have lupus more quickly. Dusenberry suspects a lot of it is that women's fatigue and joint pain tend to be dismissed. Like, well, everyone's tired, or you're just getting older. That's what the joint pain is. And fatigue and joint pain are the most common symptoms for people with systemic lupus to initially present with. So that's just one way in which this kind of gendered understanding of the experience of the body can result in the dangerous situation of someone having a serious condition that needs to be managed with things including medication, or in the case of lupus, sun avoidance, but the patient isn't getting that diagnosis in a timely fashion because of ideas about, oh yeah, women are always complaining. That's another one. Women are hysterical, so when they complain about these symptoms or they mention pain, they're exaggerating. All of these ideas, all of these gendered biases are very much playing into the healthcare system. But that's what Maya Dusenberry argues. She also talks about the underdiagnosing of women's heart attacks because they also present differently than men's. And a lot of ER staff just have the impression that heart attacks are really only affect men. and primarily men of a certain age, a certain weight, but none of that is true. She also talks a little bit about racial biases, and it's pretty shocking, and just how much more likely a Black woman with systemic lupus is likely to be accused of opioid seeking when she says she's in pain than a white woman like me. That was one of her examples. So if you identify as a woman, I would strongly recommend reading this book. It underscores the importance of self-advocating. That means when you go to the doctor and say, I have fatigue and I have joint pain, and the doctor tries to dismiss it, you have to be assertive and say, no, this is debilitating. This is hurting my life. This is hurting my experience with my family, with my work. And you really have to be insistent, which I know is hard for many of us, especially people who identify as women. And in terms of learning how to do it, it's a really tough thing. Being assertive doesn't come naturally for a lot of us. And especially if you have some kind of mental disorder, including BPD, it can be really hard to be dismissed, to have your concerns ignored, to have your words undercut. That can be really triggering. So one tip I have for that is just to practice the dialogue that you plan to have with your doctor, psychiatrist, nurse, social worker, whoever it is. Find a partner or friend you trust and just practice what you want to say. You can ask the person practicing with you, try to be resistant to what I'm saying. Let me understand what it will feel like, how frustrating it will be if the person doesn't listen to me or tells me I'm being unreasonable or hysterical. Try to get those emotions out now during your practice. It may be that the interview with the clinician goes so much better than you expect, but I think it's better to at least do a rehearsal of the feelings you might have so that it's easier to control them if you start to feel emotionally dysregulated because of an unempathetic clinician. So that's one tip. The other one isn't just about self-advocacy, but about telling your story. So as I mentioned, people studying narrative medicine are learning to understand stories better. Just like in school, when you had to read certain poems and analyze for the themes, narrative medicine can help doctors and other treatment providers to analyze what you're really saying and what themes are coming through in your patient's story. For example, with a person like BPD, those themes might be emotional dysregulation, feelings of chronic emptiness, flashes of uncontrollable anger, things like that. So it is like analyzing a poem. Every patient who goes into a doctor's office is a poem that they have to understand. And I think actually that could be one way of making yourself feel a little more confident too, that you are this beautiful text that a doctor needs to try to read. But it is difficult to find themes in complex stories, just like it is difficult for many students to analyze really complex poems or short stories or novels. So I think that when you take your story to the first visit with a new treatment provider, spend some time thinking in advance about what you want to say. Write it down. It doesn't have to be perfect grammar. You're not going to turn it in. You can have bad spelling, but kind of plan out what you want to say. I think that can make the communication go more smoothly, even if the doctor is asking questions that don't quite address what you want to get to. At least you can say at the end, well, also, I want to add this. And you can kind of think about the best way to express your complex feelings. I think there are a few ways to express those feelings, especially if you really don't know what you're suffering from, whether it's a mental health problem or a physical health problem. So a few tips for that are to get creative. Find a metaphor or simile to help you describe your pain. And I'll give you an example. One common simile, a comparison between two things using words like or as, is to say that BPD feels like walking through the world with really thin skin or with third-degree burns all over your body so that the slightest touch is agony. That is a powerful simile that can help both the patient and their doctor to understand what this person might be going through, what might the diagnosis be, and thus what might the treatment plan be. And if words aren't really your thing, draw a picture. draw a picture. It could be representational, like a picture of your face, the expressions you often have due to your pain. It could be more expressionistic. Just think of something like Edvard Munch's The Scream. Some people actually think he had BPD. If not, he certainly painted a work of art that encapsulates at least some of my past moments with that painting. You could print out a picture of that if you feel like that painting really captures how you're feeling. Definitely bring a list of symptoms in some form, whether it is just a straightforward, I wake up and I have a backache, or it is one of these pictures or similes. Another thing that might be helpful if you're having trouble explaining in words or images how you feel is to print out a meme that you've seen on social media. Certainly for BPD and bipolar disorder, I see all kinds of memes, and some of them are really articulate. So you could print out one of those and bring it to your first appointment, or even just a social media post, like someone wrote up on Instagram or Facebook their experience with a mental health disorder that you feel like you might have. Bring that in. So those are some tips about giving your story so that it's more likely to be received loud and clear. But my final tip is about, as a patient, just remembering to listen. Because I know for me, when I'm in great distress, it can be difficult to listen to other people. And it may be that, yes, the doctor is having trouble understanding or empathizing because of their own blind spots. But in order to have that successful act of interpersonal communication, you also need to keep trying to listen hard. Don't focus on anything else. Try to focus on what they're saying and what that means to you. So I hope these tips are helpful. I really wanted to get them out after taking a course in narrative medicine. And as always, I wish everyone the best of luck and take care of yourselves. Bye-bye.